we could be working down at 4, 5, 5, 6. And it's the same thing. I could produce this, and I'm not quite sure which joint it is. If I come down now onto 4, and I hold that there, and I pick up 5, and I derotate 5, and it increases the pain, then it's going to be the joint above. If it makes the pain better, it's going to be the joint below. So this can be done at every level. So there's nothing very, I mean, there's a lot of subtle stuff about this, but it can be done in a variety of ways. It's the principle. Can I take two joints, and can I increase and reduce the stresses on the joint above and the joint below to try and give me some idea of which joint is producing the pain? So this can be done at any level, and it's kind of quite useful. But I think sometimes we get to a point where you've got all these tests and it becomes more and more and more academic. And the problem is, as people move away from clinical practice, they spend more and more time teaching, which means they spend more and more time in hotel rooms by themselves, okay, or sitting on the toilet, you know, in the thinking position, and they start coming out with all these kind of theories. And before you know where you are, after you've taught them on 3 courses, this is absolute gospel truth, and it's been proven. And many of these started off as a really good idea, but then we haven't really validated a lot of this stuff. And that's what Bogduck did so well with Gwen Jull. She determined that this was the joint. He put the injection in, headache went. And she was 100% correct. And it'd be very nice if we could work along with somebody like that. A sort of, I was going to say as arrogant as Bogduck, who knows exactly what he's doing and how brilliant he is, but at least he's worked very closely with Gwendolyn Jull on this, and she was so correct. And it would be very nice if we could say, okay, now I really think that this is 1, 2 by doing that. So, yeah, 1, 2 goes, or it makes no difference. So we now wonder if our test's valid. But I think principally it sounds like a good idea. And I've been using this sort of off and on. I mean, you know, you sort of have your times when you use things, don't you? And this was a thing about Cyriax. He had his group of stuff that he never varied. That's why he came up with consistent findings. The rest of us, you know, have a group of tests, and then we kind of, it's now another week, and we go on another course, and it's another test we get. And sometimes I wonder whether we do too much stuff. But that's the challenge that we've got to do. And for each one of us, we need our own synthesis. And we need our own principles that we are happy with from courses that we've done. And that's the group of things that we're happy with. And it might differ a little bit from Sandy to Suzanne to Alexa, but we should still be able to come up with the same findings, however we slightly go from this. So I think that's a good little group of things to do with. As far as the vertebral artery is concerned, by tomorrow, or say in the next couple of days anyway, I'd like you to read the article by Bogduck. I'd like you also to just look at the article in the notes here by Ruth Grant, on looking at the Australian protocol for looking at dizziness. This is one of the things that's out there in the literature now, and if we have a problem, perhaps if we've got some literature that we can say, this is the standard practice, this seems to be the legal argument, this is the standard practice out there, that's why I did it that way, then that's defensible. What would a reasonably competent person have done? And this is what a very competent person would have done. So we're sticking on the high end of this problem.
Is that the protocol?
Yes, just the protocol. That'll be in the E section as well, E25, 28, sorry. Any other questions on that? So let's just, for a short period of time, just make sure that we all understand those principles. Then I'd like you to perhaps come down to the intervertebral joint motion and just run over those, how you are doing those, just to ascertain now that we've got no problems, we've worked out which joint it is. Now we'll have a look at what's the flexion like at the AA joint, what's the extension like, or at the OA, and what's the side bend like, what's the rotation like, and so on. So at that stage we know that we can do a little bit more testing just to ascertain which joint is going to require to be moved. And then we need to have a look at, just review the manipulation procedures, and also I think just to review 1 or 2 of the mobilizing procedures in this area, because on the whole mobilizing is still the big important techniques here, but sometimes you're mobilizing away, as you know, and you just don't seem to be getting anywhere. You do a little release and it makes it so much better, and then you can go back to the mobilizing again. Any questions on this? All right, let's go into the groups. Yes?
Interpret with joint motion of blood, have augment with side bending or side flexion of spine.
Yes, okay, let me just talk a little bit about that for a sec. This was the thing that we did yesterday, and that perhaps could come up a little bit higher too, when we're looking at how we focus at other areas. Now, this side bend thing is very useful for a whole variety of reasons. If we're coming down into the movement at the AA joint, we know that we could take up the slack of the posterior ligamentous structures and then go through that rotational motion like this. All right? But it might be better, as we discussed yesterday, to go into a side bend movement like that and have a look at the last few degrees of rotation of the C12 in that position. Now, I'd like you just to do this and then to sort of think over the next day or so, how could I use this in relationship to looking at the vertebral artery also? Because this is a very important thing when we do this. Can we, in fact, eliminate symptomatology around C12 by this side bend thing here with rotation to the opposite side? So this is just to go through this and make sure when you're testing this, and also we'll do this as a manipulative procedure, but when you're testing this, you've got to make sure that you retain the side bend. What I'm going to do with Chris here is to produce an excessive movement, okay? I'll do it slowly and stop me if it's giving me a problem. But I could be sort of here and looking at Chris and saying, don't hold yourself. Oh, geez, look at this. We're getting more and more movement here. But what's happening is I'm pulling him out of the side bend. And if he lays down on the table here, and I do the same thing, and this is what happens all the time with these techniques. Just lay on your head on this. That you will take the head into a position to the side here like this, and then what people do, instead of just doing that, which is the movement, they do this. Wow, got a lot of movement here. But you see what's happening to the side bend? I'm allowing it to go. You've got to keep that side bend in. There, that's the movement. But once I start getting this, then I'm losing the side bend lock. And it would be very difficult in Barb's case to do this because she's lost side bend down here. So if there is a loss of side bend in the rest of the neck, the only thing you can do with the side bend technique, now for assessment anyway, is to try and put the neck into the correct side bend on both sides. So she's limited on one side, and then I look at the rotation and I get some idea of where his chin is in relationship to some point on the chest, and then I could come round to this. I'll have to try and get exactly the same side bend and then look for the rotation on that side. But there's no question this works better as a test when you've got good side bend and you can really lock up the rotation to the side of the side bend. And as a manipulative thing, I think that's mandatory. That you've got to get it right round there if it's going to be stable enough to do. So let's just go through that as a very important review of all the things that you've done on all the courses up till now, because it's so important. Any questions now? Or I'm going to see brilliance from you this morning. I know I am. I know I am. Anne's got her special thing on. She's trying to emulate teacher. Okay, let's go to the tables. Thanks very much, Bill.
I need to know.
Now, the test, the little examination. And this will have no fear for you, of course, because you are all qualified up to the mobilization level, of course. All right? What I'd like you to demonstrate now for Anne and Chris and myself are the following techniques, okay? Mobilizing we're talking about. I'd like you to do a side flexion mobilization of the occipito-atlantal joint. I'd like you to do a mobilization of the occipito-atlantal joint looking for backward and forward glide. I'd like you to do a mobilization of the AA joint, looking for flexion, and a mobilization of the AA joint, restoring rotation, emphasizing the forward gliding facet or the backward gliding facet. Now, we'll work in pairs, of course, and everybody needn't do every single thing, okay? We'll just make up, this is a team effort now, that we'll just see how you do on any of these. You can choose what position you like, but of course what we want is the optimum position. So you're demonstrating not whatever positions could be, but what you feel is the most important and efficient position to do these techniques in. And then we'll come round making notes, and then those that don't look so good, we'll bring them out to the front and embarrass you. Okay, we'll just see where you are with these things. So let's go for the most efficient technique possible. And if flexion was restricted, I would think that it would be the forward gliding one that is causing the problem. But I go into a little bit more subtly and just test it. Will this move forward? Will this one move backwards? I think that's the best way of doing it, not necessarily looking for active movements.
It always seems that the backward one is so tight that it's hard for me to appreciate. I mean, the forward one always feels like, there's a lot of...
Well, I think a lot of the time that has happened because the backward gliding one is much more stable. And people with restriction tend to sort of produce extra movement on the forward gliding one. The only restriction for that would be the alar ligaments and the transverse ligament. And the capsules, of course. I mean, there's a fair amount of stuff that stops it. But it's still soft tissue, whereas going the other way, we're getting a bone going against bone as the anterior arch of atlas comes against the dens. And as the facets move down into much more of a close pack than moving forward. So, there's much more stability in extension than there is in flexion. But I think when it comes down to it, the best thing to do is to sit the patient down and just ask, can you sit down a second, Chris, for me, please? With Chris here, and I sort of just slump down a little bit. Okay. Coming into this position of testing here, put a slight side bend on so I don't have to worry about the side bend. Then I'm going to take hold of the axis fairly firmly like this, and I'm going to do that for the forward gliding one. All right? And then for the backward gliding one, and this would be the technique that I would use for mobilization as well, I hold that steady. So this I now try and create a stiff joint, if you like, on this side, and the technique now would be to use my body backwards like this. That's what I'm looking for. Will this one come forwards? Will that one not go backwards? Now in Chris's case, this one is definitely more stiff, and probably I should, when I look at his rotational movements, let's have a look here as he comes back. Now, can you go forwards? Just in that movement there. Now come backwards. This one is a stiffer movement going back, so it's probably the backward gliding one that's giving the trouble. So let's have a look at this side. There's definitely more reaction on that side. I don't know whether you can feel this, Chris, than on this side. So perhaps I should be coming into here, picking up the axis like this, making sure that I derotate it a little bit to make sure that there is no movement going to take place below it, and now I use my body. And this is a very, very important modification of this technique. My body takes him backwards.
So you're still mobilizing?
I'm still mobilizing into the backward gliding movement of the atlas on the axis, now using my body there. And I'm not allowing this side to move forward, so I'm like creating a false stiff joint on this side. And this business of using the body in this way within slight side bend opposite is a very, very subtle kind of improvement of this technique, and it's something that I think we should do.
Yeah, so I've always done it
Yeah.
from below,
Yeah.
and that's often painful to
Yeah. Yeah.
so pokey.
Yeah, yeah. But, I mean, there is nothing wrong with doing this and doing that. I think there's something wrong. We had a little discussion with Suzanne and Boyd just a little while ago about, is it a possibility if we get, let's say, an a joint restriction, that we come forward like this, all right, and we find that the forward gliding one is, was it the forward or the backward gliding one? The backward gliding one is stiff. Should we produce that by producing a movement of the atlas? My feeling is we never should do that. We should always stabilize the atlas and move the occiput, because we've got a very, very freely mobile joint below. And if we've got a restriction of that motion, and it's created by inability of the occiput to move into rotation, the chances are that the atlas and axis have taken up the whole load, and if we start moving the atlas, it's just going to move it against the axis, which is already excessively mobile. So my feeling is that we should leave the atlantoaxial joint alone and not do any of this movement from below, because it's going to be moving from below, however we work it, on the axis. And I think we should keep it fixed as far as the atlas is concerned and just move the occiput. What are the rest of your feelings about that? Yes.
You know, with that C1, C2 backwards glide mobilization, and maybe you just answered this, but again, why can't you just push forward with your fingers as opposed to just bringing back? I still don't understand.
You can. The only problem with this is that it's a movement that the patient will not under any circumstances recognize if you do that. And you've got to try and give exercises and so forth to try and keep this mobile, otherwise it'll just stiffen up. And if you've been doing all your movement by taking this, say, into this position and then moving the axis like this, there's no recognition of this as a movement for them to do it. And so when I'm doing this, I could at least say, now just see what you're doing here, and I want you to sort of put your hand around this side now at home and keep it there, and I want you to look back over your shoulder up here, and I want you to take your head back that side like that. So it's very easy to switch from the mobilizing to the active exercise. But if you've done it all by keeping this still and pushing this forward, then I don't think you achieve that same end. I don't have any objection, though, in terms of a problem with increasing difficulties lower down with that. If you want to sort of hold the atlas and move the axis on the atlas, probably okay, because you're moving it on 2, 3. But I do have objections, I must say, to moving the atlas to get movement of the occiput, because the chances are that the atlas on the axis has already done more than it should. So if you're moving the atlas forward to get sort of movement of the occiput, I think that you're just straining the atlantoaxial joint, and I don't think you should do it. But if you come further down, I have no particular problems, except I think it's just a difficult movement for patients to recognize. Yes?
You're moving backwards with his occiput and atlas as you're rotating to the
Yes,
right
yeah.
with your body.
Yes, yeah.
It's a backwards.
It's a backwards right movement in the presence of left side bend. Yeah. With a stabilized atlas. Any other questions about that?
You don't create the left side bend, but you just kind of go along with it?
No, actually I sort of create it a little bit, I must say.
And you couldn't, it wouldn't be effective to do you couldn't really do a forward glide on the right from this position, it just wouldn't work. Well, you'd have to change sides. Yes.
No, you could.
Could you do it back?
No.
Could you do it back?
I could do, let's say that's the difficulty, okay? All right, I can do a backward glide on the same side, and I can do a forward glide on the opposite side.
And if the other motion were different,
Then I would go
you'd have
to change side, yeah.
just because it wouldn't be.
It just is not efficient, yeah. Yes, Bob?
Well, we did something a little bit different.
Come and demonstrate it so we can have a look. bring the bone. And you're also going to be on film here forevermore.
He has to slump way down because I'll never be able to. Can you slump way down? You can? I have to have a box to stand on. Okay, what we did, I'll show first on here, is we turned to the limit, and then to emphasize the backward glide of Atlas on axis, we held the occiput and rotated C2 forward. Is that not good?
That's what we did.
Huh?
I mean, that's what we just talked about.
But you, so, okay, is that what you think that's not good? Well, he was saying he didn't think he should move Atlas
I know.
on occiput, but here I'm holding this and moving axis.
You know, all I was saying is that if the stiffness is in the OA joint, I think we should fix Atlas and move occiput. I don't think we should be moving the Atlas about in the reverse direction, because probably the compensatory mechanism has been thrown into the atlantoaxial joint. And every time we move the Atlas, of course we're moving it on the axis.
But this was to mobilize AA.
Okay, and so how did you do that?
So we rotated then
Yeah.
to the limit
Yeah.
and held the occiput and then rotated C2 forward.
Okay, now you can't,
Emphasize,
yeah, you can't hold the occiput though. You've got to hold the Atlas.
well, we held both. I mean, we held like this.
All right.
I'm-
Okay, you've got to get onto the Atlas though.
Right.
Yeah, all right.
And then we rotated C2.
Okay, and I would have no difficulty with that one, as I said, because you're moving 2 on 3, aren't you?
Right.
You know.
Yeah, and then for doing, well, we had done the opposite, which you said you didn't like, of doing, again, holding
Yeah.
here and then moving C1,
Yeah.
because we're moving it in the same direction that the occiput is moving,
Mhm.
so it didn't seem like we were going to get motion of C1 on C. We weren't
But
fixing.
you're bound to, aren't you? Any time that you move the Atlas, it's going to be moving on the axis. That's got to happen.
Right, I was
Yeah, yeah.
thinking that I didn't think it was stressing the OA
Yeah,
joint
yeah,
though.
yeah.
If we were moving the Atlas in the same direction that the occiput was moving,
Okay.
so that it was again stressing the forward glide of
Mhm.
the Atlas on axis.
Yeah. Yeah.
Does that sit well with you or not?
Well, that's okay. That's okay. Yeah. Good. Thank you. And
Is either more optimal or less optimal than another, or does it just depend on the local factors?
I think it depends on the local factors. I certainly think when we're dealing with the AA joint, probably because I've done it and I have no real reason for saying it's any better. I just think that this, where you're using your body and we're getting this, the Atlas to move on the axis, is very, very useful, rather than just getting this and twisting this around. That's all. I sort of think it's so useful to get on the bones that are affected rather than trying to do it by some kind of devious means. But I've no means of saying to you that one is any better than the other, except to say that it's easier for him to recognize what I'm doing than if I hold this still and I start twisting that, because he's not going to have any concept of how to bring about this rotation. And I shall want Chris to sort of put his hands up on this bone here and to tilt there and just to take the head back like that. I shall want him to be doing that as an exercise and looking over his shoulder, and that's been very easy to take from the exercise, because I can say, all right, you can feel me, I'm going back on this side. Now that's what you've got to do, not just keep this side coming forward. You've got to lean backwards, you've got to do that. That's what it's all about. And if you don't keep doing that, then we're going to create all sorts of problems on this side. But he won't know anything like that if I'm moving from caudal to cephalad, because that's not the way that we build up movement in this area.
Is it absolutely essential to incorporate the side bending?
I think it is. I think it is. Although we've got some free movement, I think it's better to not have to bother about that. So I think it's better to put some side bend in, myself. Although it might not be absolutely essential.
Is the side bend for the upper cervical or for the lower cervical?
No, it's for the upper cervical and it's for the alar ligaments. But we know that there is some free movement of rotation without worrying about the alar, so it's probably not totally necessary. But remember that what we're probably doing is we're getting back to perhaps an extreme range now when we're doing this. So this is the thing, do we sort of work out that we've got 20 degrees or whatever? It's probably better just to incorporate that when we're doing it so we don't put any stress. Because remember that when we're doing these things, and these are slow movements, these are probably the things that ligaments are less able to withstand than the quick movements where they stiffen. Any other? Yes?
I'm just wondering if you could stand on the other side. I realize it's a little bit more awkward to get the left side bending component in, but it seems like you can use your hands better to facilitate the right.
It's very difficult to, instead of using your body?
Right, so you would stand
So you mean to kind of do this and push back here? You can do that, but it's nothing like as satisfactory. This is so satisfactory to come back with the body.
For the OA.
For the, yes. Oh, no, and for the AA. And for the AA. It's so satisfactory. It gives you the extension, it gives you the backward glide.
So you're really using your thumb and your body.
Yes, yeah.
Can you show flexion one more time? The flexion, rotation, emphasizing the flexion.
Oh, yes, I would simply be over this way and I would just pull that forward like that. Keeping my body still now and pulling this one forward. That's a very easy one to do.
So the variation then is just where your hands are placed?
No, the variation is whether you use your body or your hands. This time, body still, hands forward. This time, hands still, body backwards.
No, the variation between OA and AA.
Oh, yes, purely on where you put your hand. Yeah, purely where you put your hand. For the side bend, one that all of you did, many of you sort of did this. I think you've got to incorporate, when you do this, a little bit of a rotation as you do this into side bend, so that if there's any stability taking place with your hand around here of the axis and it can't move, that you don't put any attenuation on the alar ligament. So I would definitely do that and a little rotation as I was trying to get that side bend. Now if I was doing it in lying, which I like as a position, and I'd just like to point out one or two things because I'm not quite sure that chiropractors do this correctly, and I'm not sure about